because it actually wasn't my first choice when I entered medical school. I had always wanted to work in a helping profession. I originally saw myself possibly as a teacher, actually, working with young people. And then I decided that perhaps it would be interesting to study medicine and go into the field of something perhaps like psychology, psychiatry. I like the idea of communicating with people and understanding how, the mind works. And also I was interested in the broader context of health, so social, psychosocial, cultural influences on health and well-being. So I think I went into medicine with this idea in mind, believing at the time that something like psychiatry would be that pathway. And I really did discover very kind of surprisingly and abruptly when I did a psych term as a medical student that in fact it is quite a specialty and it's quite medical, and it really didn't always, in my view, take that broad holistic approach to healthcare. And it was not until I did a lecture in adolescent medicine where I thought, oh yes, this is what speaks to me. So I had this idea that I would go into adolescent medicine, and at the time, and still in fact in Australia, that required paediatric training. So I did embark on some paediatric training, but I actually started my family just after that, and I was quite young, and basically there was no part-time training options at the time. That has changed obviously now for this generation of medical graduates, but I only really had one option for training, and that was general practice. So I must admit I was a bit reluctant to go into that, but I'm so glad I did, because general practice is actually the place, and primary healthcare and preventive healthcare is the place where you actually do really work with people in their environment, in their culture and in their communities. And that's what I loved about general practice. However, because I really did enjoy working with adolescents and young people, I kind of found my way eventually into adolescent and youth health to work as a clinician, and then after that as an academic. And I really feel very, very privileged and lucky that after kind of starting in one place when I entered medical school, I ended up in really quite a different place, but it's just perfect. It really suits me very well to have that balance of direct clinical work, that's primary care and preventative care and very holistic, but also with research and education and the links with policy and how you can perhaps try to contribute at that broader level to health and well-being of a whole population. In adolescent medicine, I followed the professor who gave that talk became a bit of a mentor to me, and I did an elective term with his department, and that involved me going into a high school and doing a sex ed class with this professor. And I really enjoyed that, because I was going to be a teacher, right? And there I was kind of with a class group in a high school, talking about the kinds of things that we never learned in high school, generally about puberty, periods, and a bit of sex ed. And I think I was still obviously pretty young myself, in fact, technically probably still an adolescent or very young adult. So I think I was still living that in my life, and kind of thought, wow, this is what I wish I had just a few years earlier. So I was very interested, and have been all along, in sexuality, healthy sexual development, and sexual health and reproductive health, and young people's rights to information and services and healthcare. And I think that came in some ways, from a personal perspective as a young woman, and feeling like for some reason we didn't have those rights, partly because of culture, partly because of stigma. And that's improved a lot over the generations, but it's still not quite there. So I think I was always very interested in, I guess, adolescent development, but particularly, sexuality and how it evolves and how it's constructed and construed by the society around us and what we grow up in. So I always had that interest as well. So kind of combining that with working with adolescents has also been a real privilege. it's really, follow your passion. And if you don't have a passion, don't worry. Sometimes people say to me, but what if I don't know what I want to do and I don't actually have one passion? I did not know that I would end up where I ended up. It was not the plan. And yet, because I found that spark as a medical student, something to do with, teaching and sharing of knowledge and learning back from your audience and I learn as much from young people as they learn from me, I believe. I mean, I have certain technical skills and certain technical knowledge that they don't have, and I will share that, but I learn just as much back from them about how this all works for them and what, and what life is like for them. So I think, somewhere in your journey as medical students, you may find just that one thing or perhaps a couple of things that really spark your imagination, stimulate your interest, or perhaps you already have that passion. And, you will find your way. I think medicine is now so subspecialized and getting into training programs is so competitive and so stressful. It was definitely in some ways easier when I was a graduate, even though I only had one option for part-time training. I would still say I still was able to find my path. But if one door closes for you, there will be another one, just as I found. I chose to start my family young, and I have absolutely no regrets because my children are all now independent adults, and I still feel I've got a lot of work and life I can live. So, but it slowed things down, and I had to juggle that. The same in a medical career, there is life to be lived as well, and just pursue what really interests you, even if it takes a bit longer or you have to find a couple of different ways to get there. Now, research, there's always research to be done, and certainly as medical students even, but certainly medical graduates, there will always be research to be done. And there's a number of ways you can get into that. You can do it through, your medical degree projects that you have. You can do it subsequently. Let's say you go into general practice training. There is something called an academic registrar post, where you spend a year learning how to do research and teaching as well as doing some clinical work. If you go into a different specialty, then there may or may not. Well, there are projects actually in sort of physician training. You have to do projects, and that involves some degree of research. You may take a year to do something like a public health degree. I did that. I did a Master of Public Health, kind of in the middle of having a family, actually. And that was a really great degree to do when I was sort of working quite part-time and but learning something that really excited me. So there are many ways into research, and research informs our clinical practice, so it's always going to exist. And whether it's taking some time off to do that and focus on that, or whether you try and integrate it into your clinical training, whatever that ends up being. So that's a very long answer to your question. It's just, it may not be the conventional path. Don't stress about that. I feel that, equity, depressingly, in some ways, there have been improvements over the time that I've worked in medicine, and in other ways things are getting harder and worse. So to give you an example, when I started off early in my career in adolescent health, starting to sort of specialize in terms of my clinical work, but also in terms of my academic work, I would say that, GPs, and I was training as a GP, on the whole didn't understand adolescent health, didn't find adolescent patients very easy or fun to deal with. They were hard to communicate with. I think that's changed dramatically. I still teach GP registrars every year, and I would say now for the last several years, we have GP registrars who are well informed about adolescent health, about psychosocial health assessments, and are really interested in working with adolescents and understand some of the challenges around that. So I see that's something that's really improved. On the other hand, working within the health system, I find that it has become more fragmented, it's become more expensive, it's a little bit harder to sort of help young people have really coordinated, streamlined healthcare, and it's kind of just a bit messy. And I think the inequity comes through when you have young people who are disadvantaged in any number of ways, so socioeconomically disadvantaged, perhaps marginalised because of their sexuality or their gender identity or their cultural background, or perhaps, disability, chronic illness, any number of things that can make it harder for an adolescent or young adult to receive the kinds of healthcare that they need. That's where I see inequity has probably, increased a little bit. I work as a doctor, clinically I work in the public system, and I work in Western Sydney, in very disadvantaged pockets of disadvantaged communities, pockets of communities with young people who are homeless or at risk of homelessness or who are otherwise marginalised. And I feel that it is harder now than it was when I started 25 years ago, for example, to help them access, if they need to see a physician or a surgeon or one of the medical specialties that are housed within hospital clinics. It's actually harder to get them appointments and to get them seen. Same with mental health. I mean, we know that there's much, much more awareness and has been for many years about mental health. There are national and state kind of strategies to address mental health, things like suicide prevention. There's a lot more awareness, more services. We've seen in the last, say, 15 years, something like the Headspace initiative for young people in recognition of the prevalence of mental health disorders in young people. And yet I would still say that for the young people I see who are very disadvantaged and cannot afford a lot of services, that in fact it's harder. There's more inequity now. It's very hard for me to make a referral to psychiatry because they can't afford to see a psychiatrist. So these are the kinds of inequities I feel really concerned about. The things that medical students can do, and I do this, there are many levels to do this. So as a clinician, I advocate for my patients. It takes longer. It means that sometimes one consultation turns into double, triple, quadruple the length of time because I'm making phone calls, I'm requesting bulk billing, or I'm requesting a fee reduction, or I'm requesting please see them urgently, and if they don't turn up, please don't strike them off the list. I work with my colleagues or perhaps youth workers out in the community to make sure the young person can get transport to their appointment. These kinds of things we can do as clinicians. We can ring up the school principal, all with the young person's consent and involvement, to say, look, please don't, please give them special consideration, or please don't, please understand that, they're getting help for various health problems and that this is why their attendance at school, let's work together to support them rather than kind of working separately. So that's the kind of advocacy I do at the individual patient level. But at other levels, link up with your local, whether it's your hospital, your practice, your local health district, your primary health network, whatever system you're working in, be advocates for addressing inequity. So if you're interested in young people, homeless older people, if it's refugees, asylum seekers, people who are disadvantaged, you can certainly, get places on committees. You can write letters to boards of committees. You can write to your primary health network. You can write to your local member of parliament. There are lots of things we can do as citizens or as professionals to address these things. If you belong to a professional college, I'm a member of the College of GPs, for example, you can find your people within that system to get on board and do some advocacy with them. So there's all sorts of things. There might be professional societies outside your discipline or specialty. So, for example, I've just retired after 5 years as president of the Australian Association for Adolescent Health. That association has a number of objectives, but one of the things we do is advocacy at kind of national government levels, whatever, to raise the profile of the needs and kind of inequities in adolescent health. So find your people, I guess, is what I'm trying to say, and work with them, because there's certainly strength in numbers to do some advocacy, but there's also strength as, in a country like Australia, we all have our rights as citizens to speak up and to contact our local members and, to make our voices heard. So, yeah, it takes a long time. It can be frustrating. You get a bit fatigued sometimes doing a lot of advocacy, but change comes slowly sometimes, and it's a kind of like, don't give up. That would be my message.